Well, thank you, Mark, for the introduction. Ladies and gentlemen, in this presentation I will talk about the role of left appendage occlusion in concomitant cardiac surgery. And before we're going to talk about this topic, I would like to ask you two questions. And my first question to the audience is, in fact, who does support the statement that we should exclude every appendage in all AFib patients in concomitant cardiac surgery? Well, it's not a majority. Almost, maybe. My second question is maybe a tougher one. Who does support the statement that we should occlude or exclude every appendage in all patients, no matter if they have atrial fibrillation or not, in concomitant cardiac surgery? No one, just me. Okay. Well, it's a good start from this presentation. In this presentation, I will try to give you some background behind the pros and the cons, whether to do it or not. And it's actually a quite difficult question at the moment. So if we take a look at the recent guidelines from the European Society of Cardiology, we can in fact find one table talking about the role of the left appendage in cardiac surgery. And the first recommendation clearly states that we have to continue oral anticoagulation after excluding the left appendage. And this is basically an interesting one because it's a class 1 indication, and we all know that many colleagues of us just stop anticoagulation when the patient is free from AF after exclusion of the left appendage. The third and the fourth one are maybe even more interesting because these two recommendations do have a class 2B indication for LAA exclusion during surgery in AFib patient at risk for stroke. And the question is, why is this? Why do some of us believe that we could reduce stroke rate by exclusion of the left appendage? Well, basically the answer was stated by Richard Whitlock in his design paper from the LAOS 3 trial. And he is just clearly stating that there is currently no adequately powered randomized controlled data available to support this. So very clear, no RCTs available. Well, the LAOS 3 trial in fact randomizes people undergoing unpumped cardiac surgery and all of them are AFib patients to exclude the left appendage or not. And the primary endpoint is stroke or systemic embolization. And we have to wait until 2021 for the final results. The current enrollment, I checked it yesterday, is 2,777, so about 2,000 patients to go. But worldwide, about 100 centers are participating in this trial. So this trial will at least give us an answer for the AFib patients. But why is it that still a lot of people under us still believe that we have to exclude the left appendage without being supported by RCT data? Well, it is because we have other data. It's no RCT data, but there is a lot of literature supporting that this might be reasonable to do. Look at this meta-analysis published in the European Journal, which is in fact showing us the odds ratios that are in favor of left appendage exclusion based on the stroke rate of 30 days and last follow-up, which are in favor of left appendage exclusion. So basically stroke rates are being reduced by exclusion of the left appendage. Not randomized, but this is a meta-analysis. On the other end, if we take a look at this review, and forget the slides, you cannot read it, but this review in fact summarized the literature, and the upper 3 studies are in fact depicting stroke rates from RCTs that are similar between LA exclusion or not. So there is actually no benefit from both sides. However, these 3 trials were underpowered, and therefore it's impossible to draw such a conclusion. What is maybe more interesting is that these trials concluded that there are no differences in complication rates between these 2 treatment groups. This is also a more recent study from Circulation, which is in fact a propensity match score analysis in 10,000 patients. And this analysis in fact concluded that LAA exclusion during cardiac surgery is in fact an independent predictor for post-op atrial fibrillation. And at the same time, depicted here on this slide, there is no difference in survival and stroke on the long term. So in fact, this paper is telling us that we shouldn't do it. So what is currently happening next to the LAOS 3 trial? the LAA closure trial, which is not very well known yet because the design paper has to be submitted yet. But this trial is in fact randomizing patients undergoing bio-AVR without atrial fibrillation. So these patients are randomized without atrial fibrillation. And these patients undergo bio-AVR with or without left appendage exclusion. And this is in fact a study to test the hypothesis that stroke rates, which are 10% in the bio-AVR patients at 5 years, will be reduced by exclusion of the left appendage or not. The current enrollment is about 150 to 200 at this point, and we have to go to over 1,000 patients. So we are still looking for new centers to participate. So if you're interested, just contact the PI, Tuomas Kivinimi, or me myself as the co-PI of this study. So basically, what do we know? We know that there are no RCTs available, at least adequately powered RCTs, showing any evidence that LAA exclusion could diminish the incidence of strokes so far. But what other information do we have to consider if we have to exclude the left appendage or not? Well, there is actually a lot to talk about. This is very well-known data. I think you are all familiar with the data from the framing study, clearly indicating that atrial fibrillation is not a benign disease. It's an independent predictor for mortality. So it is a malignant disease, and this has something to do with the left appendage. However, no RCT data. Why is it? Well, again, framing study is also showing that the stroke rates in atrial fibrillation patients is 5-fold higher. And also, I'm sorry I did not add these more recent publications, but also the very recent papers also indicate that the stroke rates are 3 to 5-fold higher in the AFib population compared to the normal population. So again, it's a malignant disease, probably related, or at least related to a certain level with the left appendage. This is also an interesting study. This is in fact an MRI study which shows the relation between the amount of fibrosis depicted in green in the left atrial free wall, and on the other hand, the presence of spontaneous contrast and clot formation in the left appendage. So basically, the conclusion of this paper is the more fibrosis is present in the left atrial free wall, the more risk there is for spontaneous contrast and clot formation. So basically, stasis, one of the circumstances that are needed to make blood clots. And this is also something that could be taken into account whether we talk about repeat catheterization or repeat ablation or repeat surgical ablation anyway. This is also an interesting study. This is an interesting study showing the relation between morphology and the presence of thromboembolism and stroke. What you see here is the relation between the LAA flow velocity and the LAA orifice area. And specifically the patients with a diminished LAA flow velocity and a large LAA orifice area, those are the patients at risk. So we cannot say that all patients with no matter what kind of appendage are at risk for stroke. Now, there are differences. We can, in fact, differentiate between those different patients. So, in fact, the story whether we should exclude the left appendage is a little bit more complicated than just a yes or a no. And so far, we don't know if it's yes or a no. Sorry again for this slide. Don't try to read it, but this is also an older paper, an echocardiographic study indicating that the presence of spontaneous contrast is related to the presence of stroke and reduced survival. So again, a relation between the outcome parameters and the role of the left appendage. This is also some interesting data about the morphology of the left appendage. The four morphological types which were described in the JAC a couple of years ago, chicken wing, windstalk, cactus, cauliflower. Some people, they just state they don't believe that these different types exist. Well, I can tell you I see more than 100 of these appendages every year thoracoscopically in an open setting. And yes, all the appendages, they just vary in type of morphology. And what is interesting is that these different types also have varying stroke rates. And why is it? Well, of course, it has something to do with the morphology itself. I mean, the more trabeculations there are, the more lobi there are, the more turbulence is present and the more stasis and less washout is present. And these circumstances, of course, are all in favor of clot formation, therefore risk for stroke. This is, again, a very old study, but I think this is an interesting study. This is, in fact, a review from the literature, in fact, reporting the frequency and site of thrombus formation in the left atrium and the left appendage in non-rheumatic AFib patients. So non-rheumatic patients defined as all patients, except for the patient with mitral stenosis or mechanical prosthesis in mitral position. And out of this review, 1,288 patients, there were 201 with a clot somewhere in the left appendage and 21 with a clot somewhere else in the heart, which in fact means that the incidence of cardiac thrombi is 17% and 91% were found in the left appendage. So basically, by removing, theoretically, by removing the left appendage, we could diminish, let's say, the stroke rate up to 90% in these non-rheumatic AFib patients. And I want to stress this is speculation. This is retrospective data. This is not an RCT, but this is all just speculation in favor of an important role of left appendage during concomitant cardiac surgery. Same was done for the rheumatic patients, and here the data are slightly different. Here we can find 3,500 patients that were reviewed with 254 with a clot in the left appendage, and about 192 with a clot in the left atrial cavity. So basically, the left appendage in these rheumatic patients seems to be the suspect, let's say, for thromboembolism in about 60%. So again, if you want to consider to remove the left appendage in concomitant surgery, doing a mitral valve stenosis, potentially you could reduce stroke rate with 60%. It's not 100%, but at least 60%. So what is the alternative? I mean, we are there. It's a once-in-a-life opportunity, like was stated before today. We could potentially remove the most potential anatomic location for clot formation. And if this is true, it is an uninterrupted lifelong protection without any compliance issues. Yeah, whether it's economically cost-effective, of course, we have to wait for data to support this. Well, actually, a couple of slides to summarize everything what Sasha already told us very nicely. How should we exclude the left appendage? And I think the message from the talk from Sasha is very clear. Don't use sutures, don't use ligation, don't use staplers. Why? Because the very limited amount of literature available is indicating that these methods are not reproducible. LAOS 1 from Richard Whitlock, a very small study, but indicates that the completeness of occlusion of the left appendage is less than 50% using sutures and only 70% using staplers. Kanderia and Margilinov, they in fact showed us similar data, about 50% complete closure of the left appendage, only 50%. So as surgeons, we are not able to close the left appendage without a foolproof device. The foolproof device is called the clip or the AtriClip. This is the old open version. Sasha has shown us much more smooth types of new versions of this device. And the message from this device that it seems to be foolproof, at least based on the very limited data available. The data are reproducible, and once when it's in position, the position won't change, even up to 8 years, like we have seen in the last presentation. So to conclude, regard LAA exclusion in concomitant surgery, the guidelines are very clear. We may consider exclusion of the left appendage in, let's say, in order to reduce stroke rate. Why is it? Because we have a lot of arguments in favor of stroke reduction, but we don't have RCT data, and we are waiting for the results from LAOS 1, from LAOS 3, and we are also waiting for the data from the LAA closure trial in the non-AFib category of patients. So that's just a matter of a couple of years, and this to-be indication might change. How should we exclude the left appendage? I would say to follow Sasha, just use a foolproof device, and so far only the AtriClip is available to do this in a reliable way. Thank you very much.
Questions from the floor? With the mic.
Nice presentation. 2 questions or remarks. The first one, isn't the appendage a kind of organ? Can you comment on the endocrine function that may also have importance apart from the thromboembolic site? My second remark is, how do you see atrial fibrillation? Isn't that a general risk marker for stroke rather than having all to blame all strokes as origin in the left atrial appendage? You have shown, there are several recent studies showing that there is no relation in time between the appearance of stroke and the appearance of atrial fibrillation. So it may be completely different origins of these thromboembolisms rather than the appendage.
Well, it's interesting questions. I think regarding the first question, the left appendage indeed is an organ. I agree on that. The question is, what is the significance of this organ in terms of, let's say, first the expansion function? I think for most patients, the expansion function is not very relevant. But if we then focus, for instance, on the patient with diastolic dysfunction, yes, of course, this might be a potential function that could save the patient from decompensation at a certain stage of his aortic valve stenotic disease. So, in fact, as far as I know, there are no clear data to, let's say, to stratify patients between a safe occlusion in relation to the expansion function or not. The second important, well, maybe important function is, of course, the production of the diuretic hormone. And what we see in our data is that 1 out of about 25 patients do suffer from some kind of fluid retention after isolated removal of this appendage. And the consequence for the patient is usually reversible and benign in the sense that they use some diuretics for a couple of weeks, and that's it. It's not that these patients go into decompensation, it's just a matter of some fluid retention. So to summarize, I think for the big majority of patients, let's say the organ function of the left appendage is limited, in my experience at least. With respect to the second question, which is an interesting question, specifically if we take a look at the recent circulation paper, showing that there is in fact no stroke benefit at the long term. Yeah, this is a difficult question, and I think there are basically two comments that we have to give on such a study population. The first one is in fact that these data are potentially biased by the type of atrial fibrillation. Is it a standalone or is it a concomitant atrial fibrillation, and what kind of concomitant atrial fibrillation are we talking about? Is it non-rheumatic? Is it rheumatic? I mean, these are in fact different diseases. However, we don't have any data to differentiate at this stage. Furthermore, of course, we have to take into account the Chet-VASc score, and yeah, we all agree that specifically the patient with a Chet-VASc of 2 or higher are potentially the patients at risk for developing stroke, while the patient with a 0 or females with a 1 are maybe the ones that are, let's say, having stroke, having no real stroke rate, and therefore not necessitating giving them anticoagulation.
I'd like to make a comment about the hormonal problem. When we started first doing surgical maze procedures, we took every atrial appendage off, the left atrium and the right atrium. And 4 of the first 6 patients went into profound whiteouts of both chests. And it happens that the person who discovered atrial natriuretic peptide was a man named Phil Needleman, who was the chairman of pharmacology at Washington University at the time. And it was before there was an assay for it, and except in animals. And so we did some experiments together and realized that if you left the right atrium alone, which also produces at the right atrial appendage, you could get by pretty much with taking the left. We did, nevertheless, still continue to see some problems with it. And he suggested, and we did, start routinely putting patients on spironolactone, which acts in exactly the opposite direction that A&P does. And we had no further problems with it. An addition was made a couple of years later by, or a few years later by Neve Ad when we started doing minimally invasive, and he would put patients on Lasix drips. We had a couple of fellows, one Kibong Kim from Seoul National University, who spent a couple of years studying this in our lab. And he found that even if it does drop in patients temporarily, it doesn't drop much, and it comes back in about 3 or 4 weeks. So it's really not, I think, any longer a problem. We prophylactically put everybody on spironolactone, and it pretty much went away. Second thing I'd like to say is I would reinforce your concern about taking the appendage in patients with left ventricular end diastolic problems, because I think that can really lead to an issue. There are some papers in the literature on it, but they're not very clear on exactly how significant it is. So I don't think we know that answer, but if you just think through it logically, that could be a real problem. The other group I worry about is people who are extremely well-trained athletes, because they tend to have big atrial appendages that are really huge capacitance chambers for them. And so I think that in those two groups of patients, you may be, until we learn more about it, might ought to be a little bit careful about it.
Yeah, thank you for this comment. I think we all agree with this, specifically with the patient group with diastolic dysfunction, and this will one of the endpoints of the LAA CLIP trial, which only includes bio-AVR patients. So basically, all of them have aortic valve stenosis and some kind of diastolic dysfunction. And based on the interim analysis, the first 100 patients, we did not see any, let's say, indication that this might be a problem. But yeah, this is very preliminary to announce. So we have to wait for more results. But so far, it doesn't look serious. Sasha, oh, sorry.
One small question.
Bart, in your experience, do you stop anticoagulation once you've clipped the LAA and you've passed the ablation?
Well, basically in this country, we have, in fact, the agreement that we leave this on the decision of the referring cardiologist. And if we take a look at the guidelines, it's a class 1 indication to continue. However, the evidence behind it is not very strong, I believe. What we see from our data, our follow-up data, is that about 50% of our patients which were ablated successfully are free from anticoagulation. But that is left upon the discretion of the cardiologist.